We're now going into the Q&A session, which is going to be chaired by Clodagh. And I do encourage the online viewers to keep sending in your questions. So I wonder if you could turn your chairs to face the... Chris, if you could come as well. No, so they're facing you. We're going to have a mixture of questions from the audience here and questions from the online audience, and questions that have been handed in. And here. Okay. So, questions from here? Any hands up?
Please, where is the Centre of Excellence for ET in the Republic of Ireland, please?
So I think that both myself and Clodagh and Chris would all have, we're all consultant haematologists, but we would have a special interest in MPNs. Now, all consultant haematologists are trained really to look after every speciality. Now, thankfully, I'm not treating a lot of other haematological malignancy, and in our hospital, we subspecialise. Now, I'm still able to look after lymphomas and other diseases, but my area would be much more leukemia and MPNs. Now, different hospitals do things differently. So there's no centre of excellence for ET. There is, I suppose, a centre of excellence in terms of transplant in St. James's, but there wouldn't be a particular, I suppose the only thing is there are certain consultants that would have a special interest in MPNs.
Can I just ask, we say you said the GPs wouldn't know, that it's such a rare condition. Is there any way of educating the GPs or even A&Es? Because, somebody goes in there and they haven't a clue. The nurse is saying, we don't know. You might be lucky enough to meet, like my daughter, because her brother is what's ET now, he's MF. She met a young fellow that came in and she knew all about it. And he was delighted because most of them don't. Is there any way of I know we have this forum here now as patients, but is there any way of educating those people? Because I think it's very important at a community level that, they know something about it anyway,
I suppose we're all very MPN focused, and I would think that everybody would need to know everything about MPN, but so do my cardiology colleagues. I think everybody needs to know everything about their subspecialty. So I think educating the patient is the kind of key to this bit, and making ye as empowered and knowledge as possible is the way forward, that you can bring that knowledge. So I certainly have found lots of GPs are interested, and they are fascinated, particularly with the new therapies. But they look after so many people with so many different conditions that I think the key is educating the patient.
One hope for the future is that we can't expect that everyone knows everything. It's impossible. We all have our own special fields. In the future, we hope that with a unifying patient record and an electronic patient record, that even if you don't know about the disease, you may be able to access someone's notes in a different hospital, for example. That is the future. It's going to take a long time, unfortunately, and it requires a lot of investment. But if we have a way of, for example, someone in Dublin accessing records for someone in Cork, and they are unwell and happen to be in Dublin, that we're not going back to square one. But I think that is the future, and that's what we need to work towards.
Thank you. I've got ET. I'm wondering, why is hydroxyurea the first thing they try when the JAK2 inhibitors are more specific to targeting the naughty cells?
Really good question, very clever. I suppose the kind of simple way of answering is what drugs do we have the most safety information on? And that is Hydrea. Hydrea has been around for an incredibly long period of time. It's very well tolerated. It's very effective. So for the majority of people, Hydrea is probably the best drug to be on. But there are a minority of people that it is not the right thing for. And that's where our second and third line agents come in. So there is a reason that we pick something as first line. Does that make sense? Hydrea? So Hydrea is more established. It's probably less side effects than ruxolitinib. We also have to think from a pharmacoeconomic perspective, it is much cheaper. And ruxolitinib has a fantastic role from a symptom management perspective, particularly if you have a big spleen. But that's not the case for most people with ET and PV. So it really needs to be held in reserve for people that desperately need it and will benefit from it. We don't have, remember now, like, you know, I took part in the Comfort 2 studies that established this drug back in the kind of 2010s. And, you know, that's a reasonably recent event. We don't have massively long-term follow-up for these drugs, you know, whereas we have decades and decades and decades of safety information. So it's like everything in medicine, it's a balance. Yeah.
Just one other thing to add, really, and just remember the indication for treatment with cytoreductive therapies in the ET is to reduce the thrombotic risk. That's the primary indication that we give people the treatment for. So ruxolitinib, you know, the data doesn't exist specifically for that indication. That's what we're going back to what we know works for that indication. It's thrombotic risk. That's what that's the indication for treatment.
Thank you. This is just a personal question, if that's okay. I was diagnosed with ET about 8 months ago, and I'm on Hydrea, right? And about a month ago, I got a chest infection, and my doctor took me off Hydrea while I was on the antibiotic. So as well as Hydrea, I take Nexium and aspirin. So I was very sick for a week, and the following week when I had finished the antibiotic, I was still sick. I had very sick tummy and headache for a few days, couldn't eat, couldn't drink, and ended up being dehydrated, but that was okay. After that, I got a kidney infection. So it's kind of taken me a long time to come round from it, but when I went back to my doctor a week ago, so he put me back on the Hydrea again. But in the meantime, I had been to my consultant, and the platelets, while I was only off the Hydrea for a week, the platelets had gone up by 120. So basically my question is, if I go on an antibiotic or any other kind of drugs, should I stay all of the time on the Hydrea?
Unfortunately, we can't really answer personalised questions. No problem at all, but you need to take it back to your doctor. Okay. Sorry, I'm so sorry. Yeah, in general terms.
Yeah, so I suppose you mentioned the drug interactions that occur, and I suppose it goes back to a previous question in relation to GPs not having a very broad knowledge of MPN. So sometimes they might be a bit nervous of prescribing something, especially because some antibiotics can interact with a lot of different medications. They might have just been nervous and thought the safer thing to do was to stop your Hydrea for a short period of time. And it probably was quite safe for, a couple of days to do so. But if you are started on any medications and you're unsure of whether or not you can start or stop your MPN medication, it's probably best to actually contact your clinical nurse specialist or your prescribing consultant, and they can, if there's a specialist hematology pharmacist in the hospital, or if they know the answer themselves, they can provide more specific advice to you. But it is always worth checking, and I think that in that scenario, it's probably a case of your doctor said it was the lesser of two evils to hold it for a short period of time, and generally can be quite safe to do something like that. But you get more specific answers if you contact the hospital team, and there's usually somebody there that can answer that question for you.
And just in general terms as well, when you're unwell, with infection, So we don't put a huge amount of attention into, like, if the platelet goes up and somebody's sick, it's not really, we don't see that as a big message. Thanks very much.
Is that okay? Yeah, sorry.
Sorry, just a quick question. Just, I suppose it's out of interest more than anything else, but you've talked about the mutations, the JAK and the CALR. Why does it, why, you said the trigger doesn't turn off, why does it cause EV in some people, ET in some people and PV in another? So what is the, do we know? Sorry.
Yeah, no, it's actually a really good question. So I think there are a lot of factors there. So it can be gender, it can be your own iron levels, and there's other mutations. So there's the driver mutations, but there are other mutations that affect as well. But it's a very good question. But there are a lot of factors. And actually sometimes people can be diagnosed with ET at the start. They can present a high platelet count, but over time they change twice. And sometimes that's to do with the immune burden, the amount of JAK2 that's in your body as that increases, the blood count can change as well. So it's a great question, and it's one of the fascinating things about these diseases is the kind of overlap between all of them and what makes one.
Shall we come to some of the ones that have been sent in, please?
So we have lots of online questions, which is great. So
What? Here we have a question from Ireland. So what are the new treatments for myelofibrosis, and what's coming down the line? I think we've probably answered that. Chris, do you want to?
Yeah, give a summarize. So I suppose the new treatments I alluded to, we've got momelotinib in the last year, and that specifically is for patients with myelofibrosis who have a particular problem with low red cell count anemia. We know that ruxolitinib and fedratinib will drop your hemoglobin by at least about 1 gram. So if you're already anemic and you need to go on a JAK inhibitor, starting those drugs will make you more anemic and can actually make you transfusion dependent. Whereas if momelotinib has a signal that it works in a slightly different way, it targets an additional problem in the cells, and that has a better response in terms of keeping you transfusion independent. So momelotinib is the new kid on the block. We are looking at new drugs called BET inhibitors, as I alluded to, and LSD1 inhibitors, and then specific, very niche treatments that are in early phases of trials at the moment. But they are the commercially available treatments that we have available, but there's stuff on the horizon.
So we've just opened a new study in London at Guy's looking at this drug navtemadlin that Chris also mentioned, which is a really exciting agent. There have been 2 phase 3 studies in the last couple of years. So phase 3 studies are the studies that are done just before a drug gets approval. So if a drug has a successful phase 3 study, then often that will result in approval. And there have been 2 studies, pelabresib, the BET inhibitor that Chris mentioned, and another drug as well, navitoclax. But I think the one that we're doing at the moment, which is called navtemadlin, is really exciting. And this is quite an unusual study. So it's for patients with myelofibrosis who haven't had JAK inhibitors before, so haven't had prior ruxolitinib. And patients are included, they start ruxolitinib, and they're only included in the randomization phase to see if they get the investigational drug, navtemadlin, or the placebo, if they have a suboptimal response. So the patients who have a really good response to ruxolitinib alone, they don't need an additional therapy. But the patients who don't have an optimal response, they get the additional drug. And that's why I think it's a really nice study design. It's a unique study design for myelofibrosis, never been done before. So I think that's probably the most exciting study for myelofibrosis at the moment.
Point to that. So phase 3 studies are where drugs get prove their worth essentially, but how much they're worth is decided by the governments. So essentially, to get a license, they will have to go through the trial process to prove benefit, but then ultimately to be reimbursed and to be prescribable, they need to go through additional processes. So you may hear of very exciting developments in the field and are released on social media, for example, but those drugs may not be available for a number of years for regulatory purposes.
There's a nice question here from Canada. So this is somebody in Canada who's moving home to Ireland, and they're worried about MPN care in Ireland, and how do you secure an MPN specialist? So I might ask Claire to take this one because she has worked in Canada.
So I worked in Canada for 2 years. I did an MPN fellowship over there. And I think everybody talks about Canada as, you know, the perfect system. And unfortunately, there is no perfect system. What we have in Ireland, I know we talk about our drug access, that it's not perfect, but actually we have better drug access than we would have in Canada. I think in Canada, they probably have better access to care. But when you're in the system in Ireland, the actual care is very similar from Canada than it is to Ireland. You know, maybe it's easier to get scans in Canada, but on the whole, I would say to that person, don't worry about the care. I think working both systems, I can see the pros and cons in both systems, but I would reassure that person that they would get very good care when they come, and maybe that they could reach out. A lot of the times, if I have a patient, we have a lot of young patients, for example, who are going to Australia, who are going to New Zealand. And often what we do is we say, look, identify a haematologist, and we will send them all that information. And that way, if anything happens, there can always be, you know, we're very, very international as haematologists. We've all done fellowships abroad. We have a lot of contacts. So we've no problem contacting each other about whatever needs to be discussed.
There's another question here, and it's a bit of a pervasive theme, really. Coming up in a number of questions, is there a link between, I suppose, emotional stress or an emotional event and the diagnosis of an MPN? Will I answer that? I suppose we don't have good evidence to support any link between stress-inducing or causing an MPN, but we certainly know that stress has a major impact on terms of symptoms and how you perceive symptoms. And certainly managing stress is incredibly important in terms of controlling symptoms. I think that's fair to say. There's a question here from Scotland. Given I've been given advice to avoid the sun, why do most care centres never monitor vitamin D levels? Somebody else want to take that? It's from Scotland. Patrick, I don't think you routinely measure.
No, we don't. We do it if people ask us to, we check it. But yeah, I mean, typically in the UK and in Ireland, everyone will be low in the winter. We'll be a bit better in the summer. I mean, it's, you know, if you're having things like bone pain, it might be worth checking to see if there's anything that you could correct that might improve that. It's not a routine test that we do in haematology, but it's certainly something that we could look into, you know, if indicated.
And I would agree, in Ireland, a bit like things like your blood pressure, your cholesterol, we tend, it's I suppose the best setting for that is primary care. So it's something we usually ask the GPs to manage. So we wouldn't routinely check vitamin D levels in the specialist clinical setting, but we might ask your GP to have a look at it. Are there any more questions from the floor? Yeah.
Just about the stem cell or the bone marrow transplant. So you were saying like it's 50 to 60%, but what is like the outcome if it does work or if it doesn't work?
That's an excellent question. I suppose when patients are facing a transplant, they want to know, where am I going to be in 10 years, not where am I going to be in 6 months. But there are lots of phases to get to that point. And when I say 50 to 60% cure rate, what I mean is that they have normal blood counts and they don't have any evidence of MPN, and essentially the disease has been eradicated. That means that unfortunately 1/3 or 30% plus of patients, their disease will come back after having gone through transplant. And that could be 6 months after a transplant, it could be 2 years after transplant. We're continuously monitoring for that. And in some patients, that may mean that they need to go back onto MPN-specific therapy after transplant, or they may need to have top-up of donor cells, for example. About it depends on the centre and it depends on the individual, but a certain proportion of patients will die from complications of the transplant itself. So when you bundle all that together, the chances of being well, in remission, your disease gone a few years after the transplant is 50–60%. And that's why we reserve transplant for patients who are fit enough to have it and won't be at excessive risk of complications, but also for patients whose disease is going to shorten their lives much shorter than that. So it's for patients who have very little option elsewise. It's slowly rising. So we are getting better at how we treat patients pre-transplant with JAK inhibitors, for example, getting the spleen smaller. We're getting better at our peri-transplant care in terms of new antibiotics and supportive cares during transplant. We're getting better at monitoring patients post-transplant for relapse and trying to act and try and prevent relapse. But it is slowly increasing. So if we look at, for example, we did a study in St. James's Hospital at patients who had myelofibrosis pre-ruxolitinib, so before 2012, 2013, and patients afterwards, and there was about a 10–15% increase in survival. It is, but it needs to be better.
There's a question here from the United Arab Emirates. We're very international. And Nona, you might be able to help with this. How do you deal with the fear of the unknown about how the disease will be in years to come? Do you want to take that one?
I think the secret to that is stay in the moment. It's so easy when we are faced with something that we have no control over to become very, very fearful. And the worst thing we can do is go, what if this? What if that? What if the other? Feeding negativity into ourselves. And that's not going to help because we don't know the answer. And it's learning to just go 1 minute at a time, if possible. That diagnosis is one of the most scary things that can happen because you have to surrender your medical history, everything to doctors and have that faith in doctors to help you. So it's almost better to plan to go to your hospital appointments and try not to project because even the doctors don't necessarily know at that point of diagnosis what the projection might be. So just try and help yourself by dropping your shoulders because always what happens when we get a diagnosis like that, ooh, and it doesn't help the whole body. So look after your whole body. Try not to worry too much. You're going to worry. It is an anxiety-provoking decision. In many ways, it's because once you're diagnosed with an MPN, you've got it. You know you can't get rid of it. That's a certain. But what we don't know on the point of diagnosis is how it's going to go forward. So stay with what you can in that moment. I hope that's helpful.
So we have a question submitted by email on how important is iron testing and what is the standard? So I don't think there is a standard for iron testing and it depends on what disease you have. So for example, if you have polycythemia vera and you're getting regular venesections, we know if we test your iron, it's going to be low. That's a consequence of the treatment. We know the patients who have high platelet counts and we're investigating for ET, we will check an iron level to see whether it's due to, so when patients have very low iron levels, their platelets can rise. So that may be part of the diagnosis, but in terms of monitoring, it's not standard. Patients with myelofibrosis who are transfusion dependent may need to be tested for iron levels to see whether they're accumulating iron from their red cell transfusion. So that it really is quite nuanced as to what your disease is. And the test is very simple. It's a blood test. We test for how much iron is in your body from various different blood tests. But it is a very simple test, but it isn't something that everyone has to have at every single clinic visit, for example.
Yeah, and just to add, actually, we get a lot of information about patients' iron status from the standard full blood count that we do in every visit. So we can tell if someone's very iron deficient quite accurately based on different parameters within the full blood count. Obviously, if you're anemic, but even before then, if we start to see the red blood cell size decreasing, then that would be an indication there may be iron deficiency in many cases.
And we're usually kind of obsessive about not taking iron supplementation, particularly in PV. I'm forever going, don't let anybody give you iron except me. because often again in a GP setting, the practice nurses are very diligently checking iron and replacing iron, which is not what we want in polycythemia. It's a means of us controlling the high hemoglobin by making you a bit iron deficient. So giving you lots of iron will push up that hemoglobin, and that can have a disastrous effect. Kind of on the same theme, there's a question from a patient with PV in the UK who's asking, will rusfertide be available anytime soon in UK and Ireland, and how will it be of benefit? I alluded very briefly to rusfertide in my talk this morning. It's an injection that is very useful at reducing the amount of venesections somebody with polycythemia might need. But the problem with it is that it doesn't have any effect on symptoms whatsoever. And as I said, it's an additional injection, which is less desirable. So I think long term, it's probably not going to be a terribly useful tool for polycythemia. I can't see it becoming available anytime soon in Ireland or in the UK. There are certainly much more impressive and important drugs that we would want available before that. There's a kind of a very practical question here that Avril and Jonah might want to answer as well. And it's from the States, actually, from the United States, a patient with PV. Can polycythemia symptoms remain after a blood count is normalised? Do you want to take that? The answer, of course, is yes, but...
I suppose you have to look at what is the symptom. Do you know, like we were discussing earlier about mental fatigue. I don't think a lot of people kind of attribute that as being an actual quite debilitating side effect. And I do think it takes, you could come into clinic, and this is what we were saying about you can't pick someone with a chronic illness, is someone, they go into clinic and you go, your bloods are great, we're really happy with you. And they're just going, oh, I feel awful. I just, and it's really about, yeah, and it's just looking at everything as a whole, just because your hemoglobin and platelets and hematocrit are exactly where we want them to be, doesn't mean that you have to feel like everything's perfect. It's really every day giving yourself credit and, looking at your symptoms, looking at your side effects, looking at triggers. And unfortunately, it's not we fixed your hemoglobin and now you're going to be bursting with energy. It's all about looking at different things as a whole. And, I think... Yeah.
It's just not about your blood counts, exactly what you were saying there. Yeah, and again, is it a side effect of the treatment? I suppose that's another thing. Your counts are great, but it could be the treatment that's making you extremely tired as well. So, yeah, it's just reiterating, it's not just about blood counts, it's about your symptoms and how you are feeling as well. So, yeah.
The importance of the trackers and, when, as Avril was saying, you go into your GP and everything goes whoosh. So it's, being able to have your diary to say, this is how, I've been feeling, and we can, go from there and see if there's any triggers or anything we can help with.
There's a question for Patrick here. What is going to be the likely application of AI or artificial intelligence in the management of MPNs?
So this is going to be a huge area across the whole of healthcare. In haematology, generally, we know that this will improve diagnostics. Two of the areas in healthcare generally that this is being really focused upon, radiology. So we think the algorithms from machine learning may be able to better review scans than humans, possibly. There's no radiologist in the room, so I can say that. But and then the other area is pathology. So looking at the bone marrow samples potentially, and this is something that's very closely linked to haematology, and this is a huge area which may improve diagnostics. In MPN specifically, and this is something that we did at Guy's, we published this last year, we did a big study where we looked at, we used a form of machine learning called natural language processing, which is a way to take data from free text records. So everyone has their clinic letter that's provided after your clinic appointment that summarizes your visit and summarizes your diagnosis. It's in free text. It makes it really difficult to extract data from that. But using this platform called natural language processing, we were able to do that and look at specific comorbidities, other diagnoses in patients with MPN. We were able to look at all of our cohort of almost 1,000 patients at Guy's and looked at 20,000 individual patient letters, clinic letters, using this machine learning platform, and we were able to get some really interesting insights from that, namely that, for instance, one of the findings was that hypertension, high blood pressure, was the most important comorbidity for risk of stroke and blood clotting in the venous system. So that was something that we were able to do using the machine learning processes to get really large volume data and get novel insights into how this disease manifests. So I think it's just a huge area that we'll see more and more from over the next few years.
There's a question here for Maeve, interferon related. What is the latest update on supply of interferon? And then a second question from France, interferon related as well, is breastfeeding safe while on Besremi? And we can...
Hold on till I just pull out my crystal ball. We don't know. We were told initially that we would have enough interferon in Ireland until June. I think that was to be around the time that they expected licensed product to become available again. Now, we haven't had an update, and that's probably something that we do need to look into. But actually, at the moment, as I did mention, the MPN Clinical Advisory Group did do, they put a lot of work into developing guidelines to optimize the therapies that people were on during the time of the shortage. So some of you may have been switched from interferon, and that would have been done very appropriately. And you may also have had the interval between your injections extended. So we've actually really managed to stabilize our supply of interferon in Ireland, and we should be able to manage into the near future. But we also are hopeful that the regular license supply will become available again, hopefully within the next couple of months. And Besremi, I don't have a specific answer to the breastfeeding question on Besremi. I will check that and come back actually before the end of the Q&A. But it is worthwhile always just to know in terms of breastfeeding, sometimes it can kind of take a while for data to come through with new drugs in relation to pregnancy and breastfeeding. And that's very simply because we don't test drugs in pregnancy and breastfeeding. It would be really unethical to test drugs in people that are pregnant or in women that are breastfeeding babies. So it can take a bit of time for that information to filter through. So that data may not be available yet. And just on Besremi, I suppose going back to the interferon shortage, we are still quite hopeful that at some point in the relatively near future will become available in Ireland. And I think the company are more hopeful themselves at this point in time that they might be able to get a reimbursement status for the medication in Ireland. But it's just a very fine balance for the HSE to reach as well, in terms of there's a lot of high cost drugs for a lot of different conditions, and I suppose all patients need to be catered for to some degree. So don't know if that specifically answers the question, but it might give some insight into things.
Yeah, and I think in our last, about a month ago, we got the update. So our clinic advisory group, we have a member of the NCCP, which is the Cancer Control Programme, and she reached out to the HPRA, and they're the people who look after supply of drugs. And they assured us that there would be enough interferon, certainly until June when the new stock is available. But it's something that we are sort of on, basically. We keep on nudging people and reminding people and kind of annoying people, I suppose, just to make sure that we're not in the position that we were last August, where patients ran out of interferon. So we're really making sure that that never happens again, basically. Well, we'll try anyway.
There's an online question here from a patient in Ireland with ET who's got burning feet and wondering if this is related. And it sounds very much like it might be a microvascular complication, so something that Claire spoke about in her presentation. And this is the kind of symptom that we'd be saying, make sure to tell your haematologist, because we might recommend taking a double dose of aspirin, which can be really helpful for that kind of symptom. There's a question here I might direct to Chris and Patrick. What is the likelihood that the CalOR vaccine will be in use, I suppose, in regular clinical use within the next 5 years?
Yeah, so the vaccine, I think, is probably not going to be. But so there are several different therapies targeting CalR. immunotherapy. So these are cells that these are therapies that use the immune system to target cells that express CALR on the cell surface. CALR is a unique target because it's not expressed on the surface of normal cells, but it is expressed on the surface of CALR mutant cells, which makes it a really good target for immunotherapy. The vaccine, I don't think it will be. The data isn't so good for that, but there are two other antibody therapies. One is a normal type of antibody, and then something else is something called a bispecific antibody. So it has two receptors, one that targets CALR and another that attracts T cells from the patient's own immune system. That's probably one of the more likely treatments to emerge. Within 5 years, it's difficult to say. We don't have a crystal ball for that kind of thing, and these processes do take a long time. 5 years is a long time, and if these treatments are, very effective, then it's entirely possible. And then, Chris, I'll hand over to you. There's also the CAR T, but you probably know more about that.
Yeah, so as Patrick said, a lot of these treatments need time to prove their worth, and it's not just about them actually working in the here and now, it's whether they work over time. So you need to allow for patients to be followed up for a number of years after these treatments to make sure that there's not late side effects or loss of effect after a certain amount of time. So that's why the process does take some time. There is a lot of excitement about this because it's novel, it's new in a field that hasn't had much research for many decades. But whether we're going to see it at the bedside, whether we're going to be prescribing it for patients in the next few years, probably not in the next few short years. But I say to young patients in particular who are diagnosed with MPNs is that this is a lifelong disease, and research moves with time, and you may be suitable for something in 10 years that we haven't even thought about. So with a chronic condition, it's always important to be thinking about not just what's happening now, but what's going to happen in 5, 10 years plus.
And I suppose it's also a very valid point. It's important to keep up to date with new therapies. These forums are great from that perspective, but the MPN Voice website also will have all the updates as well. I think we have time for one more question, Nona, is it? So there is a question here from Ireland, a patient with ET who has stiff joints and ankles, and also is perimenopausal. And this patient is wondering how much of the symptoms are related to her ET and how much are menopause related. And that's a great question. MPN Voice have did a great webinar with a gynecologist relating to this, because a lot of the hot flushes, sweats, bone pain can all be menopause related as well. So I would definitely direct people to the MPN Voice website to watch that webinar, because it's really helpful. YouTube channel. In particular relation just to joint pain is generally not a feature of MPN. So will we wrap up there now, Nona? Okay, is there any other questions from the floor?
I suppose it's a brilliant question, and we should always be thinking about how can we cure diseases rather than how could, that should be the ultimate goal for what we're trying to do. But absolutely. But we need to think, is the cure worse than the disease? And in many of the cases, that is the case. That some of these treatments that can affect a cure, like a stem cell transplant, can sometimes significantly impact quality of life and have detrimental effects. So that's the era what we're in at the moment. What we're aspiring for is, of course, to get in earlier and earlier and earlier with more and more sophisticated treatments that can preempt the development of end-stage disease. Targeting specific mutations is difficult. So we know with CALR in particular, that is expressed only on disease cells. So that's a good target, because we can target that without affecting other parts of your body. JAK2 and JAK2 signaling is not just on the abnormal cells, it's also on normal cells as well. So if you try and target things like JAK2, which is almost all of PV, you'll end up targeting other parts of the body and dealing with consequences and side effects of that. So it's not as simple as just one gene abnormality. And in myelofibrosis, for example, often you have those driver mutations, but you have additional somatic or acquired mutations that help drive the disease as well. So it becomes more than just one gene. It's a great question, and it's where we should be heading, is to look for very sophisticated, targeted treatments like that, but the reality are a little bit more difficult than that.
Well, I'd like to say on behalf of everybody here and those online, a huge thank you to our panel. I think you've